Next on Primary Care, sleep apnea, why it remains underdiagnosed in African Americans and how early screening can reduce risk.
It's over 90% of people that are Black that have obstructive sleep apnea, and they don't know it.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. Sleep is supposed to restore the body and renew the mind, but for millions of Americans, sleep may be interrupted night after night by serious and often undiagnosed condition known as sleep apnea. Research from the Brigham and Women's Hospital through the Jackson Heart Sleep Study found that nearly 1 in 4 older Black adults had moderate to severe sleep apnea, yet more than 95% were undiagnosed. Untreated sleep apnea is linked to high blood pressure, heart disease, stroke, diabetes, and even cognitive decline conditions that disproportionately affect and impact African Americans. Joining us today is Dr. Christopher Allen, known to many as Sleep Dr. Chris. He is double board certified in sleep medicine and pediatric neurology with over 20 years of experience diagnosing and treating sleep disorders. Dr. Allen, welcome to the show. So glad to have you.
So glad to be here.
Good. Listen, sleep apnea, undiagnosed, popular subject. Tell us, what is the pure definition of sleep apnea?
And Dr. Doe, before I start, thank you for letting me just be on the show. It's definitely an honor to be here, and I'm just glad that you have me on this show.
It's our pleasure.
And the thing about sleep apnea, the hardest part about my job, I got to talk to people about things that happen with them when they are unconscious. And so I have a lot of people like, oh, I sleep fine. But then I see their bed partner and they're like, no, you don't.
Yeah,
and
a lot of times the wife is telling on the husband.
Yeah, it's funny. The first 2 words I hear out of the majority of my patients are my wife or my spouse. And so sleep apnea, and I'm going to talk to you like you've never heard about it before. And it's about airway collapse. You fall asleep, all the muscles in your body relax. Your legs, your arms, even the muscles in the back of your throat. So if this is your mouth and this is the back of your throat, when you're awake, airway's open. Air is going in and out, no problem. You fall asleep, muscles relax, and right in the back it gets small. So when you're sleeping and breathing in, this is the sound people hear. That's how snoring happens. Yeah. And then it relaxes some more, and then airway's closed. So no oxygen is going to your heart, your lung, or your brain. But they don't know what's happening back there. So your heart's working harder, the lungs are breathing in deeper, and your brain sending stress signals all over your body. Then all of a sudden, you wake up. Well, not you, your body.
Yeah.
Sometimes you. Then you fall back asleep and it happens over and over and over again. That's obstructive sleep apnea. So you're having that collapse in the airway, and what happens at night affects your daytime. So that's pretty much what obstructive sleep apnea is.
This is why mom or dad will sometime wake up in the morning and find their spouse cold.
And the thing is that, as I was saying before, when you wake, what happens at night affects your daytime. Mm-hmm. And I hear a lot of things that happen like with spouses. Like, you wake up and they're giving you that hard look in the eye like, oh, it's like, what's wrong with you? Mm-hmm. And then they'll dare to ask, like, how did you sleep? Mm-hmm. Knowing that they were going through chaos the night before. Mm-hmm. And knowledge is power. And so the biggest thing, and I will probably say this multiple times, is talk to your bed partner. Mm-hmm. Because a lot of people don't know that this is happening. And I have in my clinic, I have a bed partner form that I fill out. So they get a questionnaire. And if anything, that is more golden than what the patient is telling me. Mm-hmm. And it's eye-opening for them as well. Yeah,
so it's more than loud snoring.
It is. Mm-hmm. It's not just snoring, and I always tell people this. Snoring is not normal. Now, does it mean you have a sleep disorder like obstructive sleep apnea? No. But what it does tell you is that you need to start asking some of these questions. And one of the questions you start asking yourself is like, when you wake up, do you feel well rested? Mm-hmm. And if you do, then that's great. But if you don't, then it'll lead to the other questions. As I was saying, if you're snoring loud, pausing and breathing, you're flipping around like a fish. And then, some patients, they got to be smart and say, well, look, I don't have a bed partner, so how am I going to know?
Exactly.
But you can.
Right.
Like, how many times are you going to the bathroom overnight?
Exactly.
If you're going more than twice, that's a risk factor. If you're waking up with a dry mouth or a sore throat, that's a risk factor. A headache, that's a risk factor.
Short story. Several years ago, we were out to dinner with a couple other people and lifelong friends. And some conversation was going on, and the wife mentions, oh, we don't sleep in the same bedroom. And I said, caught my interest. I said, what? You don't? No, he beats me up. He said, when he sleep, he beats me up. That kind of limb activity at night during sleep made her move out of the bedroom. Subsequent questions later, yes, he snores, has a dull headache in the morning, he needs a nap in the afternoon, he's irritable. Okay? If we don't dig into these types of things and the questions to ask the patients, we may not draw this stuff out. I mean, there's a responsibility we have to do the interview properly with these folks, to start talking about symptoms, signs and symptoms that they may have that help us make the diagnosis of sleep apnea.
Most definitely. And the hardest part about that, and I know with like all providers and being a provider myself, I have a wonderful job where I get to talk about sleep all the time. And I understand that any office might have other things that they're talking about. Yeah. And what happens is that what you can do is just ask a simple question, like, how are you sleeping? And how are you perceived sleeping? Because those are two different things sometimes. And the hard part about it is that I always joke, like, I'm not a sleep apnea doctor, I'm a sleep doctor. And there's many sleep disorders that can happen. Right. So it might not just be obstructive sleep apnea from what I was talking about. Like, for example, you're talking about that short story and you start saying that your friend is like fighting in his sleep. Well, if that's happening, those are sleep disorders that can potentially be parasomnias, which is the fancy way of saying I move in my sleep. But then also with sleep apnea, getting that treated can help so many things.
Absolutely. We're talking about better control of a lot of disease states, and particularly high blood pressure. I think over the years, we chased high blood pressure that was partially responsive to medical treatment, only to require a change, an increase in medication, and over time, and not having the diagnosis of sleep apnea or entertain the diagnosis of sleep apnea, we were mistreating those patients, because I've had dozens of patients where I couldn't control their blood pressure until I could control the sleep apnea.
Most definitely, and I'm glad you brought that up, because I have many patients that have high blood pressure and they have hypertension, and once they get their obstructive sleep apnea treated, I'm talking with them and they're talking with their provider to say, like, we're talking about coming off of medication.
Absolutely.
And one of the things that I was telling you about, when you have that pausing and breathing, those stress signals, like I said, they're going through your body, and guess what they're also doing? Increasing cortisol, increasing your blood pressure.
Absolutely. Oxygen desaturation at night on a sleep study, very dangerous. Tell us about that.
And so when you're sleeping and you have a sleep disorder like obstructive sleep apnea, your oxygen is going in a roller coaster. They call it hypoxic burden. It's a fancy way of saying that, like, when you are not breathing, your oxygen is going down. And this is going to sound hyperbole, but it's true. You're literally like choking overnight, repeatedly. And so your oxygen should never go below 90%. And sleep studies, I've seen patients where they go down into the mid 80s, 70s, 65. And your body recognizes it, because your body's really good at noticing when there is danger and stress. And so it'll wake up and you're still asleep, and the oxygen will go back up. Then it'll come back up and down. And that stress on your body can increase blood pressure and the cortisol, and that will rise. And then your body's holding on to calories. And so people that are trying to lose weight and you have a sleep disorder like obstructive sleep apnea, your body's in survival mode every single night.
So why are we missing the boat? We have a disease state here that is thoroughly undiagnosed.
And frankly,
especially in African Americans.
Yeah, I mean, there are so many reasons. The first is always trust. As a people, we have to trust our medical professions, but they have to give you a reason to trust. And then the next reason is education, from being a provider and being a doctor and making sure that they're aware of it. That's one of the big reasons why I like to be on social media and I talk about it, because I meet them where they're at. So they might be on the toilet, on their phone, looking at a video, and I'm telling them, snoring's not normal. They're like, wait a second. And the cool thing about that, I've had many people that will message me or send me a personal message just saying like, thank you for talking about this. It made me talk to my doctor. It made me push my husband to go get checked by his doctor to see if he has sleep apnea, and he's getting treated next week. And so we need to put it out there, because the hard part about it, and you already talked about the numbers, it's over 90% of people that are Black that have obstructive sleep apnea, and they don't know it.
Chris, this is a topic that, as we said before, is thoroughly underdiscussed, underdiagnosed, undertreated. Tell us about the treatment for sleep apnea.
Well, when I talk to my patients, the first thing I tell them, because TV is really good at talking about like CPAP therapy, and people will hear about that, but if not CPAP, they'll hear about the mask. But what I tell them is that there are many ways to treat obstructive sleep apnea. CPAP therapy is one of them. And so for people that hear CPAP, or the mask that some people call it, that stands for continuous positive airway pressure. And that last word is the most important part, pressure. You wear a mask and it provides the pressure to keep that airway open that I was talking about previously, and air will go in and out no problem. And the thing is that it also depends on the severity, because there could be a mouthpiece that you can use that's called a mandibular advancement device. And what it'll do, like if this is your mouth, it'll move your jaw forward while you're asleep, and it keeps your airway open. It depends on the severity. You have medication that you can use. There's a weight loss medication that is tirzepatide that's been FDA approved to treat moderate to severe obstructive sleep apnea. And there's even myofunctional therapy, depending on the severity, where you can strengthen your muscles to help keep your airway open. So there's many ways.
Yeah. A lot of the dentists have gotten into, dipped in and out of this in terms of devices and appliances, and also exercise approaches to treating patients with sleep apnea. There is an interest there that is kind of untapped when we talk about this disease.
Yeah, and that's the cool thing about being in sleep medicine. There are so many people that I get to collaborate with. I get to collaborate with like otolaryngologists or ENT doctors, even dentists, and I have a couple of colleagues that help me within my practice, where if CPAP is not an option for them and the patient doesn't want it, they'll be able to treat that. And I've been able to be fortunate to speak at dentistry conferences where I get to talk to them and tell them my side from the medical perspective, and then even be more enlightened about how they're treating our patients for sleep apnea as well too.
So we see a lot of evidence in terms of the physiology of sleep that relates to other disease states. I think one of the most recent we've had in the last few years at least is the use of positive airway pressure in congestive heart failure patients, or in general how we use positive airway pressure in the emergency room in patients who can't breathe, especially buying people time before intubation for whatever the disease state that they have. And it's been a very useful tool for us to move to that arena to say, hey, this what we know about positive airway pressure that we learned from sleep apnea can now be applied in other areas. You mentioned earlier treating patients and patients coming off medications for things. We've seen things that I know you have in terms of what the sleep study shows, dysrhythmias while patients are sleeping, undiagnosed seizure activity, all those kind of things. I mean, it's an amazing field of study to say you have these other problems going on. And in actuality, the way that we do things, very few things run in a vacuum by itself. They're always related to something else.
Oh yeah, there's definitely overlap. One of the things that I love about sleep medicine is that it correlates one way, shape, or form in any concentration of medicine. And you've seen it when they are sleeping, and you have a sleep study, which is a polysomnogram. What we take notice of how you're breathing. And so if you're in a sleep lab, there is a sensor that goes like right under your nose to see if you're breathing in and out. There's a sensor to know that if your mouth how you're breathing in and out. There's a belt on your chest and then also on your abdomen. And then there's a limited EEG where we get to look at your brain waves to see what cycle of sleep you're in. And sometimes, and then also you have EKG leads and then leads on your legs. So it's not just seeing if you have obstructive sleep apnea, it's looking at your sleep total with a sleep study or a polysomnogram. And through that, you know, with me being a neurologist as well, there's been times where I've seen seizure activity, or if I'm looking at the EKG and I'm like, okay, I see an arrhythmia that's happening, or you can see that their heart might increase or decrease depending on the events that are happening. And so that's the beautiful thing about sleep. Your sleep is restorative, but if there's any problems, it can lead to any of those problems that we talked about in different concentrations.
Is there a difference in the presentation of men and women?
So yes and no. So before menopause, you think about men. Obstructive sleep apnea is more common in men. And then during menopause and right after, then they're very similar to each other. Also, women are usually ones that will have more problems within sleep, and that comes with a regulation, like with your nervous system, because you think about, and this is throwing men under the bus, me included, because you think, like, well, first of all, when you're younger, you just go to bed. Like, you can bounce back with no problem. So the older you get, you're getting problems with falling asleep, and you have to be more intentional with men and women. But then when women get older, get married, have children, you know, guys are like, all right, we work, it's time for us to go to bed. And we might have our stressors and worries, but then that's even multiplied with women. Not only are they thinking about trying to go to sleep, they're thinking about their spouse, their children, their job. And so that leads into other disorders as well with sleep too. So you have to be very intentional in making sure you get that quality sleep.
We're seeing the presentation of Alzheimer's disease or dementia cognitive type of disorders at an earlier age than we've ever seen before. Is there a relationship with sleep apnea?
There is. There's two ways, because when you have obstructive sleep apnea, you're going over chaos in your body overnight. So you're not getting that quality sleep. And you have to get the recommended amount of sleep. The recommended amount of sleep for adults is anywhere from 7 to 9 hours. Now, I know at home you're listening right now, it's like, wait a second, I might not be getting that. And that's when you ask yourself that question to get to that provider so you can get to that. Because when you're not getting that quality and the quantity, imagine washing dishes. And I said, you have this stack of dirty dishes right here, and it takes about 7 hours to wash. But then you give it 5 or 4 hours. What happens? You still got some dirty dishes. And so how that correlates in your brain, your body's recharging, and there's toxins that your body flushes out. But if you don't give that time, they're sticking around. And when they stick around, that hurts your body. It can lead to Alzheimer's. It can lead to dementia. And so they're noticing that more. And the more that they're noticing at a younger age is two things. One, we have better studies to see where it's happening. And then two, hustle culture is real, where people are saying, like, you know, if you're sleeping, you're not grinding. And if you're not grinding, you're not making it. But then there's been studies to show that if you get the recommended amount of sleep, you get better outcomes. And I always tell my patients, like, look, if you're out here in this world, your competition, they're sleeping.
Let's talk about the elephant in the room a little bit. That particularly for the last 30 years, we've had the advent of PD4 inhibitors for sexual dysfunction, particularly in men. Is there a relationship between sleep apnea and sexual dysfunction?
Most definitely. And it's funny, I make sure to make it adamant for every man that comes into my office to tell them that, you know, obstructive sleep apnea, and you mentioned it earlier, it leads to high blood pressure, it leads to diabetes, even stroke, even erectile dysfunction. Yeah, I said it. And the thing is that it does play a role because that's still blood flow.
Absolutely.
And if you're having that disorder and high blood pressure and that disorganization, that's going to happen. And I have a funny story. I had a patient, two stories. I had a patient where he came in very cranky, very moody, and I evaluated him, found out that he had obstructive sleep apnea. And he was kind of rude with the staff, and I'm like, all right, this guy gets one strike. And then We got him treated, and 3 months later, he came back. But before those 3 months, he had the sleep study show obstructive sleep apnea, and I was looking on his problem list. And even though I told him that, what untreated obstructive sleep apnea can lead to or make worse, and I talked about erectile dysfunction, and lo and behold, it was on the problem list. Now here's the thing, his follow-up appointment, he came back. It's a whole new man coming like, oh, there goes my doctor, how are you doing? And I'm like, okay, it's fine. And it's funny, when I was looking back after appointment, I was looking in the notes, and I saw from the primary provider that he was seeing, there was like erectile dysfunction symptoms have improved. Patient sleeping a lot better. And so he's able to tell his primary that, and so it's real.
Did he volunteer that information to you?
He did not.
That's the case most
And
times.
that's why I always tell them that, because when I do tell them, then that opens the door for them to feel comfortable
Absolutely.
to talk about it. Or I just look at their medications, and what the medications are where people are using for erectile dysfunction. So I see that, or I see it in their problem list on their chart. And so that's why I make sure that they're aware of it. And then I had a female patient that I was seeing, and I saw her for the very first time. And then at the end of the appointment, I was getting ready to leave out, and she's like, oh, Dr. Allen. I'm like, yes. She's like, thank you. I was like, why? It's like, we just finished. I'm like, you're welcome. No, you see my husband, and for the first time in a long time, he doesn't have to use any medication for his erectile dysfunction, so I thank you. And so I looked at her, and I'm like, you're welcome. And so, it's there, it happens, but that's the cool part about it, that if you get those small factors taken care of, then it can help you. And as I said earlier, what happens at night affects your daytime.
In the old days, we were discussing earlier, part of the treatment, the therapy for patients in hospital would be to push the bed outside at 11 a.m. to 1 p.m. and they would have the patients just sit out there and soak up the sunlight. Oh yeah. Okay, simply because they realized the importance that it had in terms of rejuvenating the body and stuff. Sleep is something very similar in terms of how well you do the next day. All of us have gotten cut short on our sleep at one period of time or another, and the next day you feel it, okay? We're talking about a condition that is already making you feel differently, but a lot of people have grown accustomed to it, and I'm tired all the time, it's just the way I am. They play it off. What do we do to heighten the awareness that this might be part of your problem and that you really do need a sleep study?
Education's everything. It's starting with that question, how do you feel when you wake up? It's starting with the other question.
Feel like you've been in a fight? Or
Yeah.
you have a good night's sleep?
And it starts with the other question, what is your bed partner saying about you? Because I've had patients where their spouse or their bed partner will literally record them and talk about what's happening. Snoring is like, look, you didn't believe me. And usually in the appointment, if they're in there, I already know what we're going to talk about. And most of the time, I'm going to talk to the bed partner anyway. So it takes that education for it. Also, what you said earlier, that is something that is, amazing, because in your brain, sunlight helps, and it helps regulate your circadian rhythm.
Sure.
And that's your body clock. That's your body telling you when it's time to go to bed and when it's time to wake up. And most of that is based on sunlight.
Sure.
And so when you're getting out there, and when they used to do that in the hospitals, that was really good, because, in the hospital, it's a hard setting to have, where there's bells and whistles going off. You might get sunlight, you might not. You're getting checked every 4, maybe 2 hours of what's happening. And so even if you're not in the hospital, all of that is important.
The circadian rhythm is always an interesting topic, simply because of what we know about bodily function when the sun comes up in the morning and the moon comes out at night, or when the tide goes out and the tide goes back in. All of those things contribute to it. Let's touch a little bit on home sleep studies compared to overnight study in a lab.
Yeah, and the cool thing about obstructive sleep apnea is there's many ways to figure out how to have obstructive sleep apnea. There's the in-lab study, which is called a polysomnogram, or just going to the sleep lab, and so that's what they're talking about. But there are devices where you can do it at home, and they're really good to show if you have obstructive sleep apnea. So for example, the positive predictability, or the fact to say if this is true, that means it's right, is 97%. So if I have a home sleep apnea test and it comes back saying that they have obstructive sleep apnea, that's a 97% chance that it's going to be right. Now the negative predictive value, saying that if it's negative, that's a little bit lower.
Yeah, that's what we struggle with.
Yes,
Yeah,
and so the hard part, because that percentage is around 70%. So if it comes back negative, I won't even call it negative, I'll say it's inconclusive, because it didn't rule in, and we really didn't rule it out. And so that's when we have them go into the sleep lab. But it is simple, quicker, cheaper to do a home sleep apnea test. And I will do that with my patients because I know I can get the answer quicker, so we can get them to treatment faster.
This has been exciting. Good, and thank you for coming, Chris, and all of the information you provided. We've got 200 more questions for you, but I don't think we're going to get to them today. Thank you so much. Good. We'll get you back again. Very good.
Thanks.
Our guest has been sleep specialist, Dr. Christopher Allen of Quality Sleep and Neurology. Sleep is a critical component of cardiovascular, metabolic, and cognitive function. If you snore loudly, wake up tired, or struggle with high blood pressure that's difficult to control, talk to your primary care provider about being screened for sleep apnea. Thank you for watching. For Primary Care, I'm Dr. Lonnie Joe.